At a time when healthcare spending seems only to go up, an initiative in California has slashed the prices of many common procedures. The California Public Employees Retirement System, or Calpers, started paying hospitals differently for 450,000 of its members beginning in 2011. It set a maximum contribution it would make towards what a hospital was paid for knee and hip replacement surgery, colonoscopies, cataract removal surgery, and several other elective procedures. Under this new approach called reference pricing, patients who wished to get a procedure at a higher price hospital paid the difference themselves. And reference pricing is the topic of this week's Healthcare Triage. For example, in 2011, the Calpers maximum contribution for a knee or hip replacement surgery was set at $30,000. A Calpers patient receiving knee or hip replacement surgery at or below this reference price paid only the usual cost sharing, 20% of the cost up to a maximum of $3,000. As Calpers initiated the new approach, 41 of the several hundred hospitals in California could provide knee or hip replacement procedures at or below $30,000, and with acceptable quality as measured by things like low readmission rates and high rates of use of guideline infection controls. But some hospitals charged more than $100,000 for the exact same procedure. The results of knee and hip replacement surgery reference pricing were striking, as were those for cataract removal, arthroscopy, and colonoscopy. A series of studies found that under reference pricing, Calpers patients flocked to lower-priced hospitals and outpatient surgical centers. Prices and total spending for the procedures plummeted. For knee and hip replacements, lower-priced hospitals saw their market share increase by 28%. As higher-priced ones lost market share, many chose to reduce their prices. Prices for the procedures fell by an average of more than 20%, saving Calpers and its patients $6 million over 2 years. Under reference pricing for cataract removal surgery, the average price paid also dropped by nearly 20%, saving $1.3 million over 2 years. For colonoscopies, $7 million was saved, a 28% drop. And for knee and shoulder arthroscopy, prices fell by about 17%. For these procedures, Calpers reduced patient cost sharing if they chose a freestanding outpatient surgical center as opposed to a much more expensive hospital as well. During the period of time Calpers saw 20% price declines for reference price services, typical healthcare prices paid by an employer-sponsored plan rose by about 5.5%. Now, despite the success of the effort by Calpers, reference pricing is not a full solution for rampant healthcare spending growth. Because it relies on encouraging patients to visit lower-priced hospitals and surgical centers, it only works with procedures for which patients can reasonably shop around. This excludes care over which patients have little control, such as that provided in emergencies or while they're already hospitalized or incapacitated. One study estimated that only about 40% of healthcare spending is for services for which patients could shop. But there's another reason reference pricing is hard to install broadly. It requires patients to have ready access to comprehensible price and quality information. Such transparency is not commonplace. And even when this information is available, consumers with cognitive impairments or who are overwhelmed with illness and other demands would have trouble making the best use of it. Some consumers might prefer to delegate to insurers the decisions about where to obtain care. In narrow network plans, for instance, insurers select high-quality hospitals and negotiate the best price. Patients pay the same amount out of pocket no matter which hospital they visit within the network. Reference pricing shifts some of the burden of figuring out where to obtain care from insurers to consumers. On the other hand, compared with narrow network models, it preserves broader choice for the consumer, which many people like. Reference pricing also requires sufficient competition among hospitals. If the number of hospitals in an area is too low, patients won't have a choice about where to receive care, and hospitals won't have an incentive to reduce prices. Assessing the degree of competition, quality, and choice for the purposes of establishing and updating reference pricing imposes an administrative cost that should be weighed against any savings. For this reason, some large employers are contracting with regional centers of excellence, to which patients can be referred even if there is limited hospital choice in their hometowns. Another concern is that reference pricing could encourage lower quality, as healthcare organizations cut costs to reduce prices. The research cited above didn't find adverse effects of reference pricing, though. One of the authors has been quoted saying, and I'm quoting, "significant reductions in cost with no change in quality. That's called improved value. And improved value is a good thing for almost everyone.
Healthcare Triage is supported in part by viewers like you through patreon.com, a voluntary subscription service that allows you to support the show through your monthly donation. We'd like to thank our research associates Joe Sevitz and Karen Green, and our Surgeon Admiral, Sam. Thanks, Joe and Karen. Thanks, Sam. More information can be found at patreon.com/healthcaretriage.